So we're going to talk a little bit about hemodynamics and new tools on the horizon. The three things I'd like to touch upon are the estimation of mean pulmonary artery pressure, how cardiovascular magnetic resonance compares to echocardiography, and then also estimating pulmonary artery wedge pressure. So both the pulmonary artery pressure and the wedge pressure are keys to our hemodynamic assessment, and a lot has happened there with some dramatic improvements in new techniques. So let's start with the PA pressure. This is a picture of 4 time frames of 4-dimensional flow imaged by cardiovascular magnetic resonance, and the patient is in the lateral position. To the right in the image, to the left in the image, we see the sternum, and to the right we see the descending aorta. And so this is sort of the RV outflow tract view. And in these 4 time frames, these are 4 time frames selected out of the total 20 time frames during the cardiac cycle. There is, in that first time frame, that red high velocity blood flow is going in straight lines. There is no vortex. But in the middle 2, encircled by the square, there's a circular pattern of a vortex. In other words, another word for a swirl. And then in the final image on the right, there's no vortex. The number of time frames that a vortex is present in the main pulmonary artery is ridiculously directly proportional to mean PA pressure. And that has now been established many times. Initially in 2008, we see on the far left the vortex time as percent of the cardiac cycle on the vertical axis versus the horizontal axis of mean PA pressure, an R squared of 0.88. In the middle, even more patients published in Radiology in 2015. Vertical axis is vortex time, horizontal axis is mean PA pressure. And then we thought this data coming out of Graz in Austria was so ridiculously good that we decided we needed to see if it worked for ourselves. And when we redid this at the time at Karolinska in Stockholm, we saw the similar results on the right. The vertical axis now is the converted mean PA pressure estimated by CMR versus the right heart cath mean PA pressure, also an excellent correlation. So this is something that is routinely able to be done, but very few centers are doing it. We believe in it because we've learned from the people that developed it. And how long does it take? Well, it used to take, on the top row, in a method that we'll just call it M2D, multiple 2D images, it takes 9 minutes on average to do during free breathing. But on the bottom, we applied something called compressed sensing, which is a turbo technique, let's call it that, to shorten the acquisition time. We can now do it under 2 minutes of free breathing acquisition routinely with excellently preserved accuracy. So this speed up technique doesn't penalize our accuracy. So we know that we can get mean PA pressure in under 2 minutes in free breathing, no contrast. How does this compare to echocardiography? Maybe echo is just as good. We know echo works fine, we think, for example, estimating the peak velocity of the tricuspid and regurgitant jet. Well, we put that head to head. Here we see on the left, the vertical axis says diagnostic yield for detection of increased PA pressure. So we were able to find over more than twice the amount of increased PA pressure when we used CMR head-to-head compared to echocardiography, and that was mostly due to normal pressures estimated by echo and increased pressure, obviously, detection by CMR. But that was only comparing CMR to echo. What about the ground truth? Well, we went on and did that compared to cath, and here we see the area under the curve for echocardiography in the dotted line, the solid line, CMR mean PA pressure with an area under the curve of 0.99 of detecting PA pressure by cath. This is really good data, and it's we're missing stuff by echo. We know that we're not perfect by echo, but with MR, it's just routinely able to get a diagnosis, a definitive and accurate one. Can we use that to help us in estimating diastolic function? Well, nowadays we can get the velocities of the E and the A wave by both echo and MRI. We can get the E prime wave both by echo and by MRI, new high temporal resolution images. We can get the PA pressure, as we just saw, on the one hand by echo by the tricuspid regurgitant jet, on the other hand by the vortex of duration by MRI. And then we have left atrial volume by biplane methodology. When we compare these head-to-head, we have excellent correspondence between echocardiographic and MRI-based estimation of diastolic dysfunction grading. So moving on to wedge pressure and its estimation, there's been a number of studies over the past couple of years. On the left-hand side, we have work by Garg coming out of the UK, where they used a formula based on the one hand, left atrial volume, and on the other hand, left ventricular mass, to estimate a wedge pressure by cath. The standard deviation, however, was 5 millimeters of mercury, which is substantial. However, the group from Gratz, again, from a writer on the right, they used a different approach. They tried to measure the velocity of the transmitral E wave by MRI and the velocities of the pulmonary vein systolic and diastolic peak velocities and combine that to get a standard deviation of 2.0 millimeters. That's a Bland-Altman of 0 plus minus 2 millimeters of mercury for estimating wedge, completely non-invasively by MRI. That's impressive precision. How did they do it? Well, they didn't just measure in the places we do by echo. If we look on the image on the right, which is a 4-chamber view with the 4D flow overlaid, normally by echocardiography we'll be measuring in the gray positions, in the mitral valve tips in gray and out into the pulmonary vein. But they were very keen to be very particular about their measurement positions, and they put their measurement positions at the mitral annulus and end systole, and at the orifice of the pulmonary vein entrance into the left atrium, with the theory being that the velocities at these orifices represent the pressure gradients. So they were able to measure the velocities and estimate the pressure gradient in through the pulmonary vein, and the pressure gradient out through the mitral annulus. And that was the basis for how they got those extremely accurate measurements. And this can be routinely acquired for those that are interested to implement it. So we have an aspiration, a 10-minute cardiovascular MR, non-contrast, non-invasive right heart cath. We take a minute to position our images. We acquire, during 2 minutes, the mean PA pressure, during 2 minutes, the wedge pressure. We take a minute each to acquire the cardiac output in the aorta and the PA flow. In total, that's 7 minutes. Let's just call it less than 10 for summary. And we get the QPQS by the cardiac output in the PA and the aorta, and we get the pulmonary vascular resistance as the difference between PA pressure and wedge pressure divided by cardiac output. But let us not forget the good old echocardiogram. So we were inspired by that work in the MRI space and went back to the echo to try to improve our wedge estimation by echo. And we first did an invasive derivation using, in this case, left atrial volume, the E wave, and the pulmonary vein S wave. We then, in the top middle panel, did an invasive validation and showed that we got 0.2 plus minus 5 millimeters of mercury in an independent test group with an area under the curve for detecting a wedge over 15 millimeters of mercury of 0.94. And then we tested feasibility and inter-observer variability to make sure we could measure all these things prospectively. I know a lot of people out there are cautious or perhaps don't measure the pulmonary vein velocities, but we showed that it was exceedingly feasible to do that in 99% of cases. And then we applied it to the prognosis, to establish prognosis in the NEDA cohort, the National Echocardiography Database of Australia. And here we see that's over 30,000 or 38,000 patients. In the bottom right, the vertical axis is the hazard ratio, and then the horizontal axis is that estimated wedge pressure by echocardiography with an increasing hazard ratio continuously with increasing wedge pressure estimated by echo. How does this compare to the other echo measures we have? Well, here we have on the top row the estimated wedge pressure using E, pulmonary vein S, and left atrial volume, and that shows us a difference of 0.2 plus minus 5, a high area under the curve, and a high adjusted, a preserved adjusted hazard ratio adjusted for age, sex, and diastolic dysfunction grade. So let's think about that. When we have diastolic dysfunction grade, if we add our estimated wedge by echo, we get more information about prognosis. Diastolic dysfunction grading is very dichotomous, whereas when we do it, get a continuous variable such as wedge, it helps us to get more prognostic information. On the second row, we did it also just using the E wave and discarding the pulmonary vein S. So just using left atrial volume and the mitral E, we got quite similar performance and preserved hazard ratio, a little bit less than when we had the pulmonary vein S. But if you just have left atrial volume and E, you can get a wedge with a continuous variable and excellent performance. And these perform better than the other approaches using mitral deceleration time or just E over E prime, as Professor Naga has shown before. So it outperformed the traditional measures. So we should probably be doing our wedge estimation continuously using echo as well. So in summary, we can estimate mean PA pressure almost ridiculously well with MRI, 4D flow, as the vortex duration time in the pulmonary artery, which is this empirically discovered relationship. It performs much better than echocardiography. We detect twice as much pulmonary hypertension when we do it by MRI. We can estimate wedge excellently by both echo and MR, standard deviation of echo being 5 and MR being 2.0 millimeters of mercury, also in a 2-minute scan. And pretty much we can nail this in a non-contrast, free-breathing 10-minute scan by CMR, and we're trying to evaluate that now prospectively. So if you at your institution are interested in this, we'd be happy to help out. It's not impossible to do, and we welcome collaborators if such are interested. I think we'll see a future with a non-invasive right heart cath by MR in patients with sinus rhythm. Doesn't work very well in for atrial fibrillation as of yet, and it's a bright future on the horizon. Thank you for your attention.